Hello, my name is Luke Wagner, and I'm the Adult Mobile Crisis Team Administrator at the Healthcare Authority. I, along with Wyatt Dernbach, will be narrating this presentation on mobile crisis response and facility-based stabilization for you today. At least since the passage of the Involuntary Treatment Act in 1973, mobile crisis response teams have existed in some form across the state. Today, team makeup, referral processes, and access vary from region to region. Some regions have dedicated mobile crisis response teams, while others have teams primarily staffed with DCRs. In some cases, staff who primarily provide outpatient behavioral health services also function as the crisis responders and are asked to stop non-crisis work activities to respond to crisis situations. In 2021, new proviso funding allowed for the increase of mobile crisis teams and has led to the first draft of the Mobile Crisis Response Program Guide. Before the end of the calendar year, we expect to begin providing training on trauma-informed crisis care, de-escalation techniques, and harm reduction approaches so that our teams can better, more equitably serve our communities and our providers can take advantage of an enhanced federal Medicaid match. We envision a near future where our mobile crisis response teams default to in-person community-based interventions anywhere in the community where they are needed. New teams are designed to respond as two-person teams to enhance safety and support diversion from emergency departments and the justice system. Our goal is for each two-person team to include a crisis-trained certified peer counselor and utilize other providers if available and needed. Once the initial crisis is resolved, many individuals will benefit from community-based follow-up services provided by the mobile teams in a location preferred by the individual in crisis. Essential functions of mobile crisis response teams include triage and screening, specifically screening for risk of harm to self and or others, assessment of the causes, safety risks, strengths and resources, recent behavioral health treatment history, medications and medical history, de-escalation and crisis resolution with a focus on avoiding the need for higher levels of care, a strong focus on peer support that is not a duplicate of the mental health professional role, but focuses on rapport and engagement with a focus on recovery. It is also important for mobile crisis teams to coordinate with medical and behavioral health providers, as well as provide crisis planning and ongoing stabilization and follow-up in the community. We see community-based post-crisis follow-up as a key component of our crisis system that can promote continued stabilization and recovery. These services will be provided in person or telephonically based on the needs of the person in crisis for up to 14 days. Follow-up services will emphasize stabilization and recovery through the strong use of peer support and other treatment approaches provided in a location that is preferred by the individual in crisis. To begin the process of improving our crisis system, the legislature provided funding in the 2021 legislative session via a proviso that has led to the addition of 6 full adult teams defined as 11 members with 1 mental health professional supervisor, 5 clinicians, and 5 peers. HCA also added 3.5 adult teams as enhancements. These were either half teams or full 11-member teams that were added to regions to enhance what they currently have. This map shows where each region where new teams or enhancements to current teams were funded through the proviso in 2021. HCA reviewed currently available resources in each region, studied the differences of each region, and utilized the Crisis Now calculator to determine where new teams should be funded. These new teams will not provide the full coverage our state needs to ensure an appropriate and rapid response, but they do bring us one step closer to that goal. As we look to the future, we see challenges that will need to be addressed to reach our goal of equitable access across Washington state. And we've outlined some of those challenges on this slide. We recommend that the CRIS Committee and the CRIS Steering Committee continue to move forward with recommendations for increased funding of mobile crisis response teams so that everyone in our state can have access to rapid mobile crisis response services. As you think about the questions we've posed on the previous slide, we'd like to offer some potential solutions to some of the questions we've asked. We believe that current funding strategies that often rely on payments only for services provided are not adequate to fund a crisis system that needs to be available and ready to respond whenever it is needed. Funding mobile crisis services as a public service similar to police, public health, and emergency services may be an appropriate strategy to ensure that these services are always available when needed. We also note that nationally and locally, we're facing a severe workforce shortage in the behavioral health field. When new positions open, they are often filled by clinicians who vacate other positions within the local or regional behavioral health system. Another challenge can be filling positions with individuals from the local community who are familiar with the particular needs and culture of the area. We may be able to address these challenges in part through the development of a new 24-month vocational degree offered through Washington State universities and community colleges. This degree would focus on training students to work as behavioral health crisis responders, much like paramedics are trained for emergency medical treatment. Finally, to ensure that we provide mobile crisis services in the most equitable and least coercive manner possible, our state might benefit from a separation as much as possible between MCR teams and DCR services, allowing us to focus on voluntary interventions in the community and only shift to involuntary services when absolutely necessary.
While most crises can be stabilized in the community, sometimes additional services at a higher level of care may be appropriate. Facility-based crisis stabilization functions to provide that additional support while minimizing the interruption to the individual and their community. Broadly then, facility-based stabilization may assess, diagnose, and treat individuals without the need for hospitalization. Two primary vehicles for stabilization include 23-hour facilities and short-term facilities, more commonly known as triage or stabilization facilities. Both models may include services such as peer support, medication management, linkage to resources and care, and crisis intervention. 23-hour facilities are also commonly known as the living room model or behavioral health minor emergency facilities. As a person may receive services there for any period under 24 hours, they are considered outpatient centers. As such, they may reference chairs instead of beds. Short-term facilities are licensed as residential treatment facilities, and lengths of stay may extend to 14 days. Services are similar to 23-hour facilities, extended to a longer duration. Historically, terms and names used for facilities providing crisis stabilization have been used interchangeably and without clear definition. Flux in the current landscape is also promoted by situational variables such as fiscal stability. Efforts are underway to develop a clearer picture of the current state and to standardize models. Aspects under consideration include referral processes, scope and breadth of services, and access to and utilization for diversion. Robust development of crisis services demands robust thought. Listed here are a variety of key questions. Questions about the workforce ask about core competencies. How do we promote equity and diversity in the workforce? Addressing workforce shortages may include strategies to increase compensation and funding, to improve access to education or broaden provider types, and to promote workplace health and equity. Challenges may include distribution of providers across the state, especially in more remote or rural areas, and contextual variables, such as housing shortages or cost of living factors. Fiscally, behavioral health services, including crisis services, often depend on various funding streams. How do we ensure broad, sustainable services? Clinical and operational questions ask about the processes involved in providing services. How do we get the right response out? How do we promote responses that are just?